Let's see, is it going there? Hey there, everybody. Yeah, there we are. We're live. Okay, I have Jocelyn Leahey here from the Invitae Corporation, and I've actually worked with Invitae for a few years. They're incredible, and their genetic counseling is incredible for intended parents that are having carrier screening, as well as embryo testing, which we'll talk a little bit more about PGTA and PGTM as we get into this. Jocelyn was just mentioning genetics is a very complex science. These people do the work of the Lord, I'll tell you, because honestly, you have got to have a really specific type of brilliance to engage this type of information. So fortunately, we have her here who can really kind of make this very simple for us. But for those of you who have a background or an understanding, I should say, of this and have questions, that's fine. And then if you kind of don't understand something at all, drop it into the chat and we'll do our best to address that as well. So the first thing I'm going to ask Jocelyn, because I think it's important, is the type of training that she's had in order to become a genetic counselor, what her education is, and what her background is.
Absolutely. And thank you so much, Ashley. I'm really excited to be here and be able to spread some information about genetics, answer some questions. And, really it is a growing part of healthcare across the board, but especially in fertility. So make sure that, any questions you guys have, please ask them, and we can hopefully get some information out there to help you as you're going through your fertility journeys. So I'm a genetic counselor, as Ashley said. Genetic counselors in general are trained to help facilitate discussions and help patients understand genetic information as it relates to them, themselves, or to their families. And in addition to the training on genetics, we're also trained to help facilitate decision making. So to help patients say, what does that information mean for me and for my family, and what are my options, and what can I do with that information? So a lot of what we do, I think, sometimes is translating. Genetics is a very complicated and complex arena. And so taking something that's very complicated and abstract and really translating it into words in a language that is really understandable, that patients can ingest, know what it means, and know how to move forward. In terms of training, so genetic counselors have a variety of backgrounds. My background is in genetics. My degree is in genetics. To become a genetic counselor, we all go through a 2-year master's program in genetic counseling. So it's a very specific degree. After our degree, we are board certified. So we have to take board exams, genetic counseling. And then depending on the state that you practice in, some states require genetic counselors have licensure as well. So there's a range of degrees, but at minimum, we've all been to grad school and taken board exams for genetic counseling.
What got you interested in this field?
So like I said, my degree was in genetics. I worked in research labs for a while, and I really liked the science of it, but I missed being in a lab. I missed the human interaction. And so genetic counseling was really a good mix of, genetics. It's a hard science, and having that interpersonal relationship and working with patients and really seeing how you can make a difference in someone's life when they're usually going through something challenging.
Got it. So the first thing that we want to talk about, and I know a lot in the previous session, a lot of people had questions about embryo testing, and we will get to that. But before all of that, there is carrier testing. And I had questions both for people who are going through fertility treatments and those who are still trying to conceive naturally. Carrier testing is becoming increasingly prevalent. As you said, it's an expanding part of healthcare. Do you see a benefit for people who are still trying to conceive naturally, or even maybe med-assisted, but not doing IVF or IUI or anything in the doctor's office, but just trying to get pregnant on their own? Is there a use for them to have carrier testing before they start that process of trying?
Yeah, so the short answer is yes. Carrier screening is recommended by the American College of OBGYNs for all women, all couples considering pregnancy or those who are already pregnant. So if you're not pregnant yet, it's not too early to have carrier screening. To sort of pause it and take it a step back, let's just talk about what carrier screening is and so why it's important. So we all, for most of our genes, have 2 copies of every chromosome and 2 copies of every gene. We get 1 copy from the biological mom in the egg, the other copy from biological dad in the sperm. So we generally have 2 copies of every gene. What a carrier is someone who has 1 working copy of the gene and 1 copy of the gene that has a mutation, so it doesn't work properly. But that person still has a working copy of the gene, so they're generally healthy. They don't know that they're a carrier with this not working copy because they have this other copy that compensates. The problem arises when 2 people are carriers of the same genetic disorder, and they both have this not working copy of the gene that they can pass on to their offspring. And so if a child inherits 2 not working copies of a gene, they don't have a functional copy of that gene, and so they can develop symptoms of whatever that disorder is. So common disorders for carrier screening are things like cystic fibrosis, sickle cell disease, Tay-Sachs disease. And so that's why we're doing carrier screening, because you can be a carrier with a working copy and a non-working copy and be at risk to have a child affected with a disease, but you don't know it because you don't have any symptoms related to that disorder. You don't have a family history of that disorder. Oftentimes people don't know they're carriers until they either have carrier screening or have an affected child.
You know, it's interesting, just to interject there. I know that I've worked with intended parents who had, you know, a genetic mutation. Obviously, they weren't aware that they had it, but upon discussing it with somebody at Invitae or, you know, someone with an education, it's interesting to learn that some of the random symptoms that we have, like, you know, maybe an inability to digest lactose or something like that, presents itself in your genetic testing. Once you're able to look, you can kind of see where that would be something that would come about. Do you find that people are surprised to learn those things as well when you're working with them, that they might have something that's pretty innocuous, it's not, you know, life-threatening, but it presents itself in their genetics?
Yeah, absolutely. There are things that can be, you know, like you said, relatively innocuous, not life-threatening, that we can discover on genetic testing and carrier screening panels. And people are certainly surprised. And in some cases, they're, you know, when you're providing maybe an explanation for why they're having a symptom, it might be a surprise at the diagnosis, but it's actually reassuring information because it's sort of corroborating what they're experiencing in their day-to-day life with actually a reason for why they're having that symptom.
Got it. So we just got a question about PGS, which, just as a heads up for everybody, and, you know, I know that that working in this space for a long time, we are used to saying PGS and PGD. Jocelyn and I will probably be saying PGT and PGTA, PGTM, which is exactly the same thing. But I'm actually going to ask her a question about that as well. But just so you know, it's not anything different that we're talking about. We're not talking about any new form of testing. So now that we're already getting those, actually the next question is about that. So PGS and PGD have undergone kind of a makeover with the name changes. Do you understand, or I actually don't understand, what are some of the reasons for the rebranding, and have the actual tests changed at all?
Yeah, so what used to be called PGS, or pre-implantation genetic screening, is now known as PGTA, or pre-implantation genetic testing for aneuploidy. Aneuploidy is just the medical term for when there's extra or missing chromosomes, so too much or too little genetic information. What previously was called PGD, or pre-implantation genetic diagnosis, is now PGTM. So PGT for monogenic disorders, testing for things like cystic fibrosis. If you do carrier screening and you're a carrier couple, you can do testing on the embryos by PGTM. So the naming changed. It's confusing. Like you said, people still refer to PGF, PGD. It's still on websites. I think part of the reason for the change was to just standardize the nomenclature. So now when you're talking about doing genetic testing on an embryo, it generally is PGT, pre-implantation genetic testing, and then there's a dash, and then it tells you what type of testing it is. So it's A for aneuploidy, M for monogenic diseases. And as new types of testing come out, the new things that come after the dash are just, those letters are going to change.
And just for the uninitiated, can you just kind of explain why somebody would why should we even care about the testing of an embryo for particularly PGTA, which is more common, but also PGT-M, in which, why should that matter to us in this conversation, in this context?
So PGTA, again, it's screening for aneuploidy. So it's counting the number of chromosomes that are present in an embryo. A normal embryo will have 46 chromosomes. It gets half from the egg, half from the sperm. We know that as women age, that the rate of aneuploidy increases with egg age. So the older a woman gets, the higher the chance that her eggs or her embryos are going to have the wrong number of chromosomes. Too many chromosomes, not enough chromosomes. Generally speaking, when an embryo doesn't have the right amount of genetic information, it can lead to, generally not a healthy pregnancy or not a healthy baby. So it can cause failed implantation, miscarriage, problems later during the pregnancy, the birth of a child with genetic problems. A common example of aneuploidy is Down syndrome. So again, that's something I think a lot of people are familiar with. They want to test for Down syndrome. Doing it pre-conception, doing it on embryos, you do that with PGTA. It's a screening test. It can be done, really on anyone. I saw that there was a question about, an age cutoff for when PGT would be recommended. So 35 is historically the age, where you become an advanced maternal age, and we talk about the risk of having a child with a chromosome abnormality. The reason that 35 was the cutoff is because that was the age at which the likelihood of aneuploidy and the likelihood of an adverse outcome from a diagnostic prenatal test were about the same. So it then became beneficial, or, the relative risk, people felt like, okay, well, it warrants testing for women who are over 35. That said, aneuploidy can happen to pregnancies of women at any age. Donors will have abnormal embryos on PGTA. So in terms of an actual cutoff, I don't know that there's a hard recommendation that it should be done on all patients over 35 and no patients under 35. A lot of it is going to depend on your physician's preference, their recommendations, what they see with their patient population, and what they prefer to do in their practice. It's certainly something, again, once you're over 35, the likelihood of having abnormal embryos does increase. And so if you want the highest chance at a healthy pregnancy, doing PGTA is the way to identify chromosomally normal embryos to transfer back into the uterus. But again, it's not required.
Right. And just so it's clear for everyone, as Jocelyn mentioned, that, yes, the Down syndrome is an example of that, but very often, as she also mentioned, it's not compatible with a healthy pregnancy. So sometimes genetic testing can just tell you that this is most likely going to result in a miscarriage. And so I know with my clients over time, I always try to keep them mindful of that in terms of deciding whether or not to have PGTA done. It is better to know which embryos are normal and which are abnormal so that you can avoid the multiple miscarriages of kind of just crap shooting, for lack of a better word.
Mm-hmm. And just to say, PGTA can also be used for gender selection. So if couples are doing IVF for the purpose of family balancing, or that's just a consideration as you're going through IVF, you can certainly tell if an embryo is predicted to be male or female by doing PGTA. And so that's another reason that people commonly do it.
Thank you for mentioning that, because that's the fun part. And that's usually why people do it anyway. So we have a question, and I'll go ahead and ask you the question before we move on. Doesn't the PGT test cause a possible deterioration of the embryo? What's the general position on this?
So that's a great question. I would defer honestly to an embryologist, since they're the ones who are actually doing the biopsy. So in order to do genetic testing on the embryo, you have the embryo in the lab, they grow it up a couple of days, they take a small biopsy out of the embryo. So by the time the embryo is at the stage we're doing PGT, you have the embryo. On one side is what's called the inner cell mass, and that's what's actually going to go on and become the baby. And then the rest of it is what's called the trophectoderm, and this is what's going to become the placenta. When we do the testing, we're actually testing the cells that are going to become the placenta. So we're not testing the cells that are going to become the baby. This does confer some limitations to testing. So again, we're not testing the actual cells that are going to become the baby. So it's possible there's discrepancies between the placenta and the fetus. But because we're testing the cells that are going to become the placenta, generally, I think doing a biopsy is considered relatively safe. It still is an invasive procedure, and with that does come the potential for risk. But I think given how frequently it's done now, most embryologists feel comfortable doing it and would say that the risks, if they are present, are small.
And don't outweigh the benefits of having the results. You mentioned it's not 100% because you aren't taking a complete biopsy of the entire thing. A look at the entire thing. It's just a biopsy. It's just a sample. Is the margin of error? It's about 2 to 3%. Is that the case?
So honestly, it really depends. Biology is it's just not a straightforward science all the time. So we just know that it's possible that the cells in the trophectoderm and the cells in the inner cell mass can be different. We've seen numbers anywhere from like 2 to 5%. So I think it's just something to keep in the back of your mind. It is possible to do PGT and have one result and get pregnant, and the pregnancy has a different result. It's not common, right? Most often the results of PGT, the results of the trophectoderm biopsy are consistent with what's actually going on in that inner cell mass with that baby. And that's why PGT has the utilization that it does, is because it's generally very accurate. But again, biology is full of surprises sometimes. And so,
yes.
Nothing is a guarantee, unfortunately.
Got it. There is a rise in the interest of genetics as related to psychiatric and neurological disorders such as autism. Is there any way to decipher a possibility of these disorders in a resulting child from the embryo during PGT?
So in terms of what is routine right now, generally speaking, no. There's not a common autism panel that we can do on the embryos to identify those that are at risk of developing something like autism. Unfortunately, a lot of cases of autism are unexplained, meaning, the child or the person has a diagnosis, but we don't necessarily know what's causing it.
Right.
So a couple things I'll say to that. One, anytime that you have, you as a patient have a concern about something in your family history, seek out a genetic counselor, because they'll be able to talk more specifically about things in your family history that may be red flags for certain genetic markers. Sometimes something that generally we say is unexplained might have an association with a key feature. And if we see that in the family, it might help us identify a genetic cause. Second, the best thing is always going to be if there is a genetic explanation, the best person to test for is the person who has symptoms. So whoever has the neurological disorder, whoever has autism, if you can get a genetic diagnosis in them, it's much more informative when we talk about testing you or testing your embryos. Yeah. And then, there was just a big fertility conference nationally, and people are talking about this. It is a common question. So if it's something that's on your mind, you're not alone. A lot of people are thinking about this and thinking about ways that we can try to identify embryos that are more likely to develop these sorts of multifactorial disorders when there isn't necessarily a clear single gene cause.
Got it. Thank you for that. That's really good to know. I think that's a really common question. And I will point out, as related to autism, that Dr. D mentioned it, but with fathers who are over, or reproductive fathers who are over 50 years of age, there is an increased risk. We don't know, what the genetic correlation necessarily is with that, but that was something that she mentioned. So just to point that back out. Jocelyn, I'm sorry.
The one other thing, so there is a disorder called Fragile X syndrome. It's often included in carrier screening panels. That's sort of the one, if someone says they have a family history or someone with autism, a sibling, a cousin, a niece, a nephew, that would be the one thing I would say. Make sure you get Fragile X syndrome testing, because that's sort of the easy first go-to in terms of genetic causes that we can.
And isn't there an ethnic, because I know there is an ethnic component to a lot of the need for some of the carrier testing, for instance, with Black people or people from African descent. There's a sickle cell propensity, and then Fragile X, is that Mediterranean or?
Fragile X is pretty consistent across all ethnicities. We do see some variation, like you said. With some disorders like sickle cell, there's a very high prevalence in the African American population, much lower outside of that. There's other disorders that follow that pattern that are very common in the Jewish population or Mediterranean. Fragile X, we don't see it quite as dramatically. So,
okay.
But it is associated with diminished ovarian reserve. So especially, in the fertility setting, it's something I think a lot of REIs are very well versed on Fragile X screening. They include it routinely in carrier screening. So it's something that, if you've seen a fertility specialist, if you've had carrier screening, you may have already been tested for Fragile X syndrome.
Yes. This is related to privacy practices. And I have had clients who have not wanted to have any type of carrier screening or even PGT because they are concerned about privacy issues and feeling like these results might be stored somewhere and, down the line be, harmful to their resulting child in some way. What kind of things are in place at Invitae, and then in general in your industry in terms of privacy practices for the results of these types of tests?
So I'll sort of answer in reverse order. So there is a law that was established in 2008 called the Genetic Information Non-Discrimination Act, and it broadly protects individuals. So basically, your health insurance and your employers can't use the results of genetic testing in the decisions about coverage or hiring or anything like that. There is fine print. I am not an attorney, so anyone who's interested can certainly, look it up and read the fine print. But generally speaking, it says health insurance providers cannot ask you about any genetic testing you may have had and use that information for coverage decisions. This law does not protect for long-term disability or life insurance. So if you want to apply for life insurance, that company legally can say, have you ever had genetic testing? If so, please provide a copy of those results. What we're talking about with carrier screening, again, it typically isn't going to affect your individual health. So, I don't know if or how that would impact insurance coverage, but again, those laws are in place. So there is some protection about who can ask you for your results. In terms of how labs use your information, I think every lab is going to have slightly different policies. I think all of the major reputable labs that fertility centers are working with, the labs that you guys are going to be exposed to, should be transparent about what their policies are. They should provide them to you if you ask for them. And you should have some ability to opt in or opt out of different types of, research with your data or how your information is stored. So, I can speak for the lab where I work. We certainly don't sell anyone's data. We're not out there, giving it away. We're not financially benefiting from your information. Ways that labs may use your data is in research. So it's typically de-identified, so it's not traced back to you. And it's research that helps move the field of genetics forward. But again, labs should be transparent about what they're doing, how they're doing it, and again, give you the opportunity to opt out. If you don't want your data used in anonymous research, you have the ability to say, don't use my information.
Perfect.
Yeah.
And unless we have questions, I have one final one myself, and then we are going to thank Jocelyn for her time. So I've worked with families before who shied away from PGT and carrier testing because they felt there was an ethical issue at hand, and not necessarily that there's anything wrong with it, but I had one client say to me one time, I want to leave, like, this whole process is so orchestrated for me, and all the natural feels taken out of it. And so, I want something to feel like it's kind of left up to chance, which I understood from an emotional standpoint. But I have also encountered people who felt like there was a gene editing or something happening in terms of this testing. And I wanted to get your take on, is there any element of editing or fixing genes? Are you changing anything in the genetic makeup through carrier testing or through embryo testing? Is there any possibility of changing the genetic makeup of a child, of a resulting child?
So no, and I understand that, you look at what's in the news and the movies, and certainly I get that thought of like, well, what is really happening to my embryos? Because you're not watching it, you're not doing it, you're trusting someone else. No. So both carrier screening and PGTA are taking genetic information from you or from your embryos and analyzing it. We're never going back and putting anything back into that embryo. We're just looking at what are the genetics of that embryo, what are that genetics of you, and giving you information so you can decide what you want to do. Do you want to proceed and transfer a girl embryo, a boy embryo? Do you have normal embryos to transfer? Do you want to, are you and your partner both carriers? Do you want to use a donor? Do you want to pursue PGTM? Do you want to just assume the risk and understand it and be educated? You have all those options. The goal is to just give you the information so you can be educated going forward.
Awesome. Jocelyn, thank you so much. I honestly, if I could go back and ask God to do something different with my brain before getting here, it would be like yours. Thank you so much.
Well, and thank you for the platform and the opportunity to hopefully provide some information to everyone listening. I hope it was helpful. And
it was incredibly, definitely for me. And I think everybody's really, really happy and excited that you had so much great information for us. So thank you, as someone said, for demystifying the process. We appreciate it.
I'm happy to help. Have a good one.
Thank you. Thank you, everyone. We are moving on to the 40-year-old mom next. So hang tight. We'll be back. Thank you, Jocelyn.
Welcome.